Okay, we got Fred coming back up here to join the panel, and now we have time for questions and hopefully answers. So do we have mics out in the audience? Yes, maybe? I can't see the audience, so you'll just have to tell me the lights are quite bright. You had a question here, down front? Row 2.
Again, thank you very much. Is there a central database for EEG longer term for the LGS patient? And is there an application of AI to see whether the drug we are giving it, are we changing the EEG?
That is a great question that does have an answer. Tracy, do you want to start with your answer? No, please. No, please.
That is a great question. So is there a central EEG database for LGS EEGs as they progressed over time? Yes, in academic centers, they do have some of these EEGs, but they're behind privacy walls and they're hard to get. So the foundation is now working to create an EEG database. We have an EEG task force to do exactly this so that we can free the data and it's not locked behind. And for a long time, researchers were not looking at the evolution of LGS. This concept, like I said, is about 20 years old, this evolution. And many in the field have not caught up with it, but we have really intelligent people working on this now, and you'll hear from some later. I know Fabio is here and others, and Renee is here, other physicians who are really interested in this evolution and how do you stop it. I think that it's going to be very important for us to look into that. The only other thing I will say is there is a company, the NeuroPace, that makes the responsive neurostimulators, and the doctor who works there, Marty Morell, has been using EEG, and her and others like Mary Zupons and Doug Nordley and others, and I don't know if you guys do this, when you have continuous recording of EEG and you put a child on a medicine, so for example, they're in the epilepsy monitoring unit or they have one of these implanted devices, doctors will say that they actually will use that to tell if the medicine is working a lot faster than waiting 2 months and let's see, right? And so this is something that's coming in the future. We do have patients that have been planted with the RNS where you're getting recording and stimulating, and then there's deep brain stimulators that are looking to do that now. But I think that it's something that is starting to happen and it's emerging, but it's not part of standard clinical practice. What is part of standard? I think we've got standard clinical practice for diagnosis now. But
standard clinical practice,
what does that
mean?
Do
whatever you want.
Do whatever you want. That sounds like America.
That's part of the problem with even collecting EEG, right? Because you're going to get EEGs from different people done at different times in their course, and so you have to start to standardize that to some degree. But yeah, the task force is working hard to do just that, and not just to see if the medicines are working. But, I showed you generalized paroxysmal fast frequency and generalized slow spike wave as the hallmarks of this disease. What if there's a different hallmark? What if there's another hallmark that we don't know about yet? There's a lot of things in EEG that we cannot see with our eyeballs when we look at it, but other platforms can find these waveforms maybe. So what if there's another one? What if there's another one that shows up many, many years before slow spike wave shows up? And if you saw that and you said, that's the marker of a person who will develop LGS, and we could do something then to prevent LGS from occurring. Wouldn't that be awesome?
So one last thing. The latter part of your question is very important, AI. I don't think we have effectively used AI yet. It's not quite there yet, but I think we have to answer the basic foundation first. But it's very intriguing. Very intriguing. Please.
I will say that we did fund a researcher at UC Irvine to look at the EEGs of this sort of evolution to LGS, what we call pre-LGS in a shorthand. And a lot of patients who had prior infantile spasms evolved to LGS. We know it's about at least 30%. Sometimes numbers come back as high as 50%. And he was able to use AI and machine learning and automation and algorithms to actually pull out 4 signatures within the LGS EEGs for people who had established LGS. 2 of them we knew slow spike and wave, and GPFA, which Scott talked about. And then there were two intensity bands that were consistent in every LGS patient. We have no idea what they are. And so really looking at those and figuring it out, those are things that we want to treat and how they change over time. And we funded a couple of animal models now that actually express slow spike and wave, so looking at the evolution in those as well. So it's something that's emerging. We are pushing it. I think all of the researchers that we work with are trying to figure out how to use AI on the EEG as well as other data, but it's still coming about.
Hi. Oh, there we go. So our daughter is a situation that doesn't seem very common in the room, where she was born neurotypical, not a health issue, and then when she was 20 months old, we were in a car accident, and she sustained a pretty severe traumatic brain injury. And so then years later, because it was about 18 months after the accident that the seizures really started. And then from there, we had to fail out of different medications before we got an epileptologist and were told the LGS diagnosis. So we've only had that diagnosis like just over a year. Is it worth getting genetic testing to kind of fine tune reasons and causes for the seizures? Because it feels like our epileptologist isn't really digging into the reasons. And then I'm looking at your med list and we're on Epidiolex, but otherwise avoid gabapentin and oxcarbazepine. We're on both of those. So I'm just kind of wondering for our situation where it's not the typical genetic feedback, what's kind of the route for us? What should we be looking at doing? And we're in Canada.
Dave, you want to take that first?
Yeah, sure. It may be somewhat atypical in your instance, but at many of the centers of persons in here, we do see this. You are correct. Being aggressive earlier is very helpful. I am very biased because I've been leaning more towards more and more genetic testing, including in cases of traumatic injuries with LGS. Sometimes you can find out perhaps something that may help, that may not be different. I'm very eager to hear what others have to say. But even in those instances, and in the case of your lovely child, everything is still on the table. The medications taken, the diet, certain types of device-type surgeries. So that's also very important. Scott?
I mean, I would say I am a genetic epileptologist, so I'm also very biased to genetics. But, you know, genetics, I guess I would say, like, what's the worst that could happen? You might find something that's really useful, you know? I mean, there are certain situations where you definitely should consider genetics. So if you have intellectual disabilities or seizures that are out of proportion to the changes that may be present on an MRI, for example, it just doesn't explain the whole picture, then there could be some other reason, and genetics is really important. And if you do have a genetic etiology where the genetics has a very specific treatment for it, that can really change therapy, you know? So we know there are certain genetic conditions where some meds are very, very good, and some meds can make things worse. So I think it's of value.
Just for a little bit of context, about half of people with LGS are like your loved one, where there was some traumatic brain injury, and the other half have a genetic, and there's several hundreds of genes now. There's a reason, so not everybody who has a traumatic brain injury develops seizures that then evolve to LGS. And I don't think science has caught up with that question yet. Right, like one of the biggest causes of traumatic brain injury in LGS is lack of oxygen at birth in our community. And so why is it that every baby who suffers lack of oxygen at birth doesn't develop seizures and then go on to LGS? And so there could be some sort of a genetics thing there, but I don't know that we're looking yet. So even if they did find something, I'm not entirely sure they would know what to do with it. But if you did, like if there is intellectual disability and things like that, it could be genetic. So I think it'll be hard to find a doctor that will order the testing for you guys, but if you can get it, I mean, it's like what Scott said, like what's the worst that can happen? But it's a question that science hasn't answered yet.
Let's see, we got, I see Dale, I can see you, and then there's somebody back there. So you go first, Dale, and
Gotcha.
then we'll go to the back.
It'll
Sorry.
be quick. Dr. Clark, you mentioned the importance of sleep, that sleep cycle. We dose 7:30 and then a little bit later, he gets a little bit more we add on. I'd almost venture to say 90% of our seizures are about, between 5:30 in the morning and when he wakes up and gets his first dose at 6:30. If he goes back to sleep, he will seize. I don't care how much medication he has in his system. But any thoughts on maybe the dosing schedule or anything we can do in the morning to mitigate some of those morning seizures?
That's a fantastic question. So, like everything else in medicine, there's a bit of nuance. I do think that managing when the seizures occur are important, but what you don't want to do is so heavily manage those times that seizures start occurring at other times. So when you're drowsy or going into sleep, the brain is much more connected. So when you're drowsy or going into the early stages of so-called slow wave sleep, that's when you get lots of active seizures and when you're coming out of sleep. So you tend to see it around those times. Each medication is given differently based on what we describe as the half-life, meaning how long it takes to break down. In the instant you told me, and I don't know the whole details, we can speak about it after, or you can engage with someone else here, it would make sense in my mind with the ones that are more heavily weighted with the longer action during the evenings to perhaps dose that later. But I'd have to know the whole context of what you're discussing. I hope that's helpful.
All right, I'm going to go to in the back.
Are you receiving a lot of kickback from the insurance companies for some of your procedures, especially like the implants and the EEG monitors? And the second part is there a correlation between excitement in the patients and having seizures, especially if there's a long buildup of that excitement? For example, her favorite Christian singer is Jason Crabb, and he came to our church. She had an opportunity to actually see him, and after just a couple of hours of that excitement, that's when she started having seizures. She had a serious cluster for almost 15 minutes. So I was just wondering those two things.
So I will say, first of all, receiving kickback from an insurance company sounds like an illegal thing. But I think I know what you mean. So do they argue with us? Yep, you bet they do. It's one of my favorite sports. It is, it happens. They are, especially for the implantable devices, because of their indications in 18 and up, we get a lot of times where we might get some argument, but I think it's increasingly getting better. I also know which insurance companies are going to argue with me. So, you can head that off to a bit when you know that, because your note can be like very, very clear why it's needed, and sometimes that helps because sometimes they actually do read them.
I would just add for insurance, as we've talked to families over the years, it's an endurance sport. So as you are, how much tenacity and how long are you going to argue with them? And then do you have a physician that will argue with you? And then you just keep every point that they bring up. You have to figure out exactly why they denied you, and then you have to go look up that specific line item in whatever their 5,100 page manual is. And then you go argue about why a helmet is not the same as a shower safety bar, right? And you just keep drilling down and moving up the chain. But and you need a doctor that will help you do that.
And to answer your other question with regards to like excitement as a trigger, there's lots of triggers for epilepsy, and they can be quite unique to different patients. And there are some conditions, for example, where we know anxiety or excitement seems to be a trigger. Parents will come and tell me these things. And my approach to this is I have no reason to believe you're lying to me. I can't explain it, but yeah, it's a real thing. Sure. One more question here. Yeah.
Hi. I thank you for having me here. My daughter has actually been hanging out with the DUCE or DOSA cluster of kids where 70% of them go seizure-free and then 30% of them do not, and a chunk of those end up getting re-diagnosed as LGS. And my question goes back to your earlier comments about EEGs. Should I be suggesting to those folks that, you should be updating the EEGs or some sort of the other diagnostic testing yet if it hasn't been done in like, say, 2 or 3 years? Or is that too soon just yet?
So you're,
You were saying you're hoping to stop the progression, which we talked a little bit about the science a year ago.
yeah, and you haven't, the EEG has or has not yet had the features of LGS?
Hers has not.
Not,
So
okay.
it's been
Yeah.
since just before her DBS, we had one. So my original question was, should I be asking the adult epileptologist to update that periodically, or?
I think there's a couple things with EEG. I think number one, there is no standardization of how frequently it should be done, you know, especially if you think something could evolve to LGS. How often should you do it? And for how long until you can say at this point it's infinitely unlikely that LGS will develop, you know, or the features will develop. I think my general rule for EEG is that, like with any test, if you're going to do the test, what are you doing with the results? And be clear, like, why. So if you have, you know, new events that you're not sure it's a seizure and you need to try to define, is it a seizure, that's a reason. If you have a change from an examination standpoint, maybe mental status or some other regression that is occurring and you don't have an explanation for it, maybe an EEG is useful. I think, you know, doing it just to look, there's nothing necessarily wrong with it. It's just, what are you going to do with it? So to tell you, oh, go get one, so to make sure it hasn't developed into LGS, I don't know that that's going to, I can't tell you that's going to change anything. You know, Dave, do you think otherwise? I mean,
No, the only thing I would add is if the seizures are persisting after 2 to 3 years, sometimes I repeat it just to see if I may have been as accurate in the first instance. Because with the EEG, you're looking at this two-dimensional image of squiggly lines, which is pattern recognition. And sometimes we do it for as short as 40 minutes, sometimes we do it for 24 hours. In that last EEG that I may have looked at, what could I may have missed something. So sometimes if the seizures persist or slightly change, I may want to repeat it to see where I am. And the one thing I didn't say, which is extremely important, and you'll likely hear later, see that cell phone that many of you carry? It's gold. So if you're concerned, pull out that, and can pull out that cell phone and capture that. It's extremely helpful to us, independent of the EEG.
okay, we have reached the 10 o'clock hour.